Okay, I think it's 1 o'clock, so I think we'll try and get started. Jeffrey Gottlieb, Professor of Medicine at the University of Washington in Seattle, United States. And on behalf of my co-chair, Richard Hayes from the UK, we welcome you to this session on It's Time to Focus on STIs. Our format today, each presenter will present a couple of slides on their poster, key points. We're going to try and hold them to a 5-minute presentation or so, with maybe 1 or 2 short questions after each presentation, then a discussion altogether at the end, depending on time. So with no further ado, our first presenter is Florence Lott from France with a talk entitled STI Co-Infections at HIV Diagnosis in France.
Thank you. So, the objective of my poster is to analyze the frequency of STIs in people newly diagnosed for HIV between 2012 and 2016. In the mandatory HIV surveillance system, 4 bacterial STIs, syphilis, gonorrhea, genital chlamydial infection and LGV have to be reported in adults since 2012 if they are concurrently diagnosed at the time of HIV diagnosis or diagnosed in the previous 12 months before HIV diagnosis. They are defined in my presentation as STI-HIV co-infections. I'm just going to present the analysis by transmission group and trends. Information on STI diagnosis was available for 12,047 new HIV diagnoses in adults during the period 2012-2016. So for 52% of cases. This proportion of documented cases was higher for MSM, 82%, and heterosexuals, 72%. STI-HIV co-infections were globally 14.4%, but were more frequent in men having sex with men. During the study period, 26.4% of MSM were diagnosed with an STI at HIV diagnosis or in the 12 months before. STI-HIV co-infections have significantly increased over time from 12.6% in 2012 to 18.3% in 2016. By transmission group, this increase was significant only in MSM, from 22.1% to 31.9%. Among the 4 bacterial STI reported, syphilis was the most frequent, particularly in MSM. 20.2% of them were diagnosed with syphilis at HIV diagnosis or in the year before. Heterosexual men were more often co-infected with syphilis and gonorrhea than heterosexual women, who were more frequently co-infected with chlamydia. Rectal LGV was diagnosed only in MSM. So in conclusion, STI-HIV co-infections have increased over time and affect almost 1/3 of MSM newly diagnosed with HIV in 2016, especially syphilis. Even in these results can't give information on chronology of STI and HIV diagnosis, they underline the importance of offering an HIV test to patients presenting with an STI, and conversely, as recommended in France, and I think in many countries, of course. In a context of STI increase in MSM and combined prevention for HIV, STI repeated screening is particularly important to treat rapidly patients and partners. I would like to thank all biologists and all clinicians who participate to HIV surveillance. Thank you for your attention.
So we're happy to take one or two quick questions. There's mics on the side, or it's a small room, you can probably yell it out. While we're waiting for questions, I have one question. In France, is there a recommended timing of STI screening and HIV positive MSM? How often is it recommended?
Yes, HIV screening or STI?
STI screening.
STI, it's for the moment it was once a year, but in fact we have now new recommendation, new HIV screening recommendation to test MSM every 3 months, and this recommendation have to include, of course, no further prevention, something which is more, which is wider, and to include also STI screening and hepatitis B and C screening. So I think that now we can say that it's what is recommended. It's every 3 months.
Can I add a quick question? Richard Hayes here. It was notable that the prevalence of syphilis was much higher than the other STIs, but presumably they would only test for gonorrhea and chlamydia if it's a symptomatic episode, or would they do asymptomatic screening?
No,
No.
they have to be tested, even if they are asymptomatic.
Okay.
Yes.
So you think those are genuinely low prevalences of gonorrhea and chlamydia?
I don't say it's a prevalence. No, I will not say that. But of course, asymptomatic STI are less screened than others. Yes.
Any other quick questions from the audience?
Jad Gaune from Paris. Florence, do you agree that the significant increase in STI in MSM precedes the introduction of PrEP in France?
Yes, but I think that for the moment, PrEP users represent a limited number of MSM, because it's about 3,000 of MSM which have initiated the PrEP. I think that perhaps we are going to observe an increase of STI, and after that, yes, if STI are diagnosed and treated, after that I think we could reduce the STI transmission.
Okay, thank you. Okay, our next speaker is Flavia Matovu. Sorry if I'm butchering your name. From Uganda, who will be talking to us about acquisition of sexually transmitted infections among women using a variety of contraceptive options, a prospective study among high-risk African women.
Thank you for this opportunity to present our findings on behalf of my co-authors and the rest of the Aspire team. I have no conflicts of interest to declare. Because of their benefits, long-acting reversible contraceptive methods are being promoted widely, including settings where the risk of both HIV and other sexually transmitted infections is highest. And in these settings, STIs are responsible for significant morbidity and mortality because of their effects on the reproductive system. In addition, STIs have been shown to increase the risk of HIV-1 acquisition, which provides further incentive for understanding factors leading to increased STI susceptibility at a global public health level. Some studies that have evaluated the association between certain hormonal contraceptives, especially depot and combined oral contraceptives, have found no increased risk of STI acquisition, while some have found increased risk. So we have mixed findings And there are very few data on the risk of STIs among hormonal implant and IUD users. And therefore, within a prospective study of a vaginal microbicide, we compared the risk of STI acquisition among a variety of contraceptive users. We analyzed data for 2,264 women, half of whom are from South Africa, and the rest were from Uganda, Malawi, and Zimbabwe. Half of these participants were on Depo-Provera, and then the rest were distributed between implants, Neten, and non-hormonal IUD. There were 817 cases of STIs that were detected over about 3,400 person-years of follow-up. And of note, women who acquired HIV during follow-up were censured at the time of seroconversion. So we saw 408 cases of chlamydia trachomatis at an incidence of 11.86 per 100 person-years, but this was not significantly different across the different contraceptive users. Similarly, we saw 196 cases of Neisseria gonorrhea at an incidence of about 5.7 per 100 person-years, and this again was not different across the different contraceptive users. The incidence of Trichomonas vaginalis was 6.19, and this was significantly lower for implants, Depo, and Neten users. And this data was consistent across South Africa and non-South African sites. So in summary, the incidence of chlamydia trachomatis and gonorrhea was not different across the different contraceptive users in Aspire, but the incidence of Trichomonas vaginalis was significantly lower for progestin-based users, Depo implant, and Neten users compared to IUD users, which is likely due to the hypoestrogenic states, which are not conducive for persistence of Trichomonas vaginalis. Our findings are strengthened by the frequent capture of contraceptive exposure and inclusion of over 3,000 person-years of follow-up, though we acknowledge a limitation of lack of randomization to contraceptive method, since this was secondary data analysis. And our results support current World Health Organization guidelines of not restricting contraceptive options for women who are at risk of sexually transmitted infections. And I would like to acknowledge our study participants, the whole of the Aspire team, and different collaborators, including our sponsors, the National Institutes of Health, and the International Partnership for Microbicides. Thank you.
Are there any questions from the audience?
Hi, Britt Gill from University of Pittsburgh. Just a few questions. The first one was in regards to the sites tested. Were these just testing for like genital STIs, or were there also extragenital sites tested?
We tested for different STIs, and they were mainly genital. All that I included chlamydia, gonorrhea, Trichomonas vaginalis, and syphilis as well, though we do not show the data. Yeah.
All right, thank you.
Okay.
Next test question was, and I might have missed this in your presentation, what method did you use to test for the presence of Trichomonas?
We used rapid Osome test.
All right, thank you very much.
Any other quick questions?
Can I?
Sure.
Flavia, can I just check, the relative risks you showed, were they adjusted for sexual behavior measures?
Yes, we adjusted for baseline sexual behavior and other potential confounders, age, baseline STIs, and so on.
Thank you.
Yeah.
Thank you. Okay, our next speaker is Jeffrey Parsons from the United States. We'll be speaking on differences in biological and behavioral HIV risk before, during, and after PrEP use among a national sample of gay and bisexual men in the United States.
All Right. Thank you. I have no conflicts to declare except for the fact that our 10-year-old son is really bitter that his dads are in Paris without him. So I promised him a selfie, so everybody smile. There we go. Okay.
We'll not let that cut into your time.
I know. Thank you. So we are conducting a longitudinal study of gay and bisexual men across the United States. That's an observational study. And we started in 2014 when PrEP in the United States had just begun. So what we've been able to do in this study, because we send them home HIV test kits and STI kits, we're able to sort of monitor the uptake of PrEP in a cohort of representative gay and bisexual men across the U.S., as well as look at its relation to condomless anal sex, or CAS, and STIs. And so what we've been looking at particularly in this sample, and the demographics, it is a predominantly white sample, it is predominantly gay identified, and most of them are employed and fairly well educated. About half of them are in a relationship and half of them are single. And what we've done with the data is we've been able to sort of chart the use of PrEP over time from baseline to 12 months to 24 months. We're just about to begin our 36-month follow-up this month. And what you can see are gradual increases over time in the uptake of PrEP, as well as some discontinuation of PrEP. So people who were on PrEP at some point during the study and then discontinued over the course. So you see at 24 months we have about 3% of people who were previously on PrEP but are no longer on PrEP. We also saw PrEP use in general increase from about 3% to 8% to 14% over the 2 years that we currently have data. We also assess in this study condomless anal sex with a casual male partner, as well as we did urethral and rectal self-testing for gonorrhea and chlamydia, and those were done through a urine-based test and a rectal swab, which were then mailed back to the lab. And so what you can see here, these are the between-group comparisons of those reporting any condomless anal sex with casual partners and those receiving a positive rectal or urethral STI diagnosis by the PrEP group across the 3 time points. And the findings were a little mixed. So we had significant differences in reporting any condomless anal sex between the groups at baseline and 12 months, with those on PrEP being the highest risk in both cases. And there were also significant differences at both 12 and 24 months in STI prevalence, with those never on PrEP being the lowest at both time points. So then we also conducted a series of within-group mixed models to examine how movement onto and off of PrEP influenced risk only among those who had been on PrEP at some point in the study. And so compared to visits when they were not on PrEP, compared to visits when they were not on PrEP, we saw a significant increase in the rate of casual condomless anal sex during visits when they were actively on PrEP, and a slight but non-significant difference once they had discontinued PrEP. So we do seem to see some indication that both condomless anal sex and STIs increase when a person goes from not being on PrEP to being on PrEP, and then a decrease again if they do discontinue PrEP. But the problem with the discontinuing PrEP group is the N is still very small. We're hoping with the next assessment we'll have more power to look at more differences there. So we found some evidence of this, and if we look at it in different ways, we get slightly different findings if we're looking within group versus between groups. But I think the most important sort of takeaways of this is that there are a lot of different types of gay and bisexual men, and we tend to lump them all together. So there are some who go on PrEP to have a backup for condom use, and they continue to use condoms primarily, and they use PrEP as sort of a secondary thing for condom failure. Some go on PrEP because they were already having condomless anal sex, and they want to continue or increase that. But some men who want to have more condomless anal sex choose to go on PrEP as a way for them to be able to do that. And as a result, they may be more likely to get STIs. STIs which are inherently treatable, and if appropriate testing and screening is being done, should be able to be caught earlier than it would be in most cases. But this is where we may be sort of letting these men down. For example, another study that we've just completed in New York of PrEP users shows that at their last PrEP doctor appointment, 94% of them gave a blood sample, 88% gave a urine sample for STI testing, Only 51% gave a rectal sample for STI testing and 48% a throat sample. So what we're seeing is providers are not doing the full range of STI testing and screening among PrEP users. And this is even in a large city like New York, where there's been a lot of PrEP education for providers. And so we think that that's an area where we really need to make some improvements, is letting physicians and providers know that they need to do the full range of STI screening with men on PrEP. And of course, the sample is limited by the fact that they were, the men who were former or current users of PrEP are early adopters, since this started in 2014. Thank you.
Any questions from the floor?
Hello. I was wondering, for the people who didn't get the rectal or pharyngeal samples, did you look to see if those facilities had labs that were approved to do those tests?
That's a great question. We don't have that data. This was a different, recently done survey where we just asked a few questions about their most recent PrEP visit. We didn't get into that level of detail, no.
Sorry, this is just basically a request for recap. Those STI testing figures, because you whizzed past them, they weren't on your slide, and I think that's really crucial. So I got 51% of STI checkers were getting rectal samples. What were the other figures?
It was 51 that got rectal, and it was 88 that got blood, and 88 urine, and 48 throat.
Right, okay.
They weren't on the slides because that's actually from a study that we just finished data collection. So it's not from the same sample.
Got you. Okay.
But I think it's very relevant to what we're saying here.
Yeah, we've just seen that PrEP adoption increased HIV and STI testing in Victoria State in Australia. That was in the last session. And of course, you've probably seen the evidence that gonorrhea is actually starting to go down, or it's very early, but evidence in London. So what gets tested is very, very important.
Exactly. Otherwise, it's a missed opportunity if we're not doing the full range of testing.
I think we're going to cut it off there because we're over time, but maybe you can ask your question at the end, if that's okay. Thank you.
Thanks. Yes, we'll try and have some further questions at the end of the session. So I'm Richard Hayes from the London School of Hygiene and Tropical Medicine. I'd like to add my welcome to this session. There are many important associations between HIV and other STIs. I think it's an area that's actually been relatively neglected in these conferences, and it's fantastic to see such a full room of people here today. Welcome, and I hope you enjoy this short session. So the next speaker is Marie-Suzanne Monti from France. She's a senior scientist at the French National Centre for Scientific Research, and she's engaged in multidisciplinary research. She's actually a very appropriate person to do this because she has a doctorate in immunology and she is a social science researcher. So a rather unusual combination of skills. And your talk is entitled Partner Notification of STIs Among MSM on PrEP. It's a sub-study of the EPA-GAY trial. Thank you.
Thank you, Mr. Chairman. Thank you for giving me the opportunity to show you some results about partner notification of STI among MSM on PrEP, and that is a sub-study of the INRS EPA-GAY trial. As you most certainly know, partner notification is a public health approach to enhance targeted STI testing and subsequent linkage to care. There are currently no specific PN guidelines in France, and information about current practices are scarce. The present sub-study was done during the open-label extension of the INRS EPA-GAY trial to investigate PN in MSM reporting a bacterial STI. 275 participants completed a specific online PN questionnaire, and among them, 250, 91% almost, reported at least one previous STI. The outcome we considered was notification to main partner or to casual partner of the most recently diagnosed STI, and we used Key2 or exact Fisher t-tests for statistical analysis. These are the results of the multivariate analysis. As you can see, regarding notification to main partner, is less likely when the condomless anal sex was practiced with a casual partner at the most recent sexual encounter. When regarding notification to casual partner, you can see that it is less likely for older MSM, while for MSM reporting practicing chemsex at the most recent sexual encounter, those MSM were more likely to notify their casual partners. So in conclusion, these very first results show that different types of determinants are involved in partner notification according to the type of partner, either condomless sexual encounters with casual partners seems to be a barrier to main partner notification, and on the contrary, chemsex practices seems to be a motivator for casual partner notification. These results provide a very first insight into current PN practices regarding STI in France and should inform future decisions about how to define feasible and acceptable PN programs. And to conclude, I wish to thank the participants, the different study staffs and peer counselors, all the different committees and our funders for this study. Thank you.
Thanks, Marion. Thank you for keeping so well to time. Let's invite some questions. Sheena.
That's great, thank you. I just wondered, are you sure that they had had sex with the main partner? Because sometimes it's not always a very active sexual relationship.
We can take that.
Okay.
Yes, we can.
Maybe I can just ask, partner notification is sometimes done by healthcare providers rather than the patients. Can you just clarify how it was delivered in this case?
In this study, about 70% of participants notified by themselves.
Okay, so there was no notification by healthcare providers.
It was a personal initiative.
Thank you. Are there any other questions on this presentation? Just to remind you that for all these presentations there are posters, which I think in many cases will have more detail, so we do encourage you to take a look at the posters. Thank you very much, Marion. So the next presentation is by Dr. Christine Wall from the USA, also an interesting variety of skills. So first degree in biomedical engineering and then a doctorate in epidemiology, and she's now an assistant professor of epidemiology at Emory University, and she's going to present a talk on predictors of genital ulceration in serodiscordant couples in Lusaka.
Thank you so much. Thank you all for coming. Is this on?
Yes? No.
I can't hear it either. Let's see.
If you're listening in the booth, can you turn on the main microphone, please?
Hello? Hello? Better? Okay. Great. Again, my name is Kristen Wall. I will be presenting data today from the Rwanda-Zambia HIV Research Group, which is based at Emory University. And I'll be discussing the recurrence of detectable herpetic genital lesions in a cohort of HIV serodiscordant couples that was recruited and followed in Zambia. We have no conflicts of interest. So by way of extremely brief background, as I'm sure most people in this room know, both HSV2 positivity and detectable herpetic ulcers are risk factors for both HIV acquisition and onward transmission. And this has been seen in several studies, including in the cohort that I will be presenting data on today, where we see that risk of HIV acquisition in women increases when women have detectable herpetic ulcers with an adjusted hazards ratio of 1.9, and you can see in the box what we're controlling for. And similarly, risk of HIV acquisition in women increases when their male partners, their positive male partners, also have herpetic genital ulcers. And then for men, we see that risk of HIV acquisition increases when men have these detectable ulcers. And interestingly, we measure baseline HSV2 positivity in this study. We don't have HSV2 data in a time-varying sense, but we do have baseline data. And baseline HSV2 positivity is not predictive of HIV acquisition or transmission once we start controlling for these detectable herpetic ulcers. And this is just an overview of HSV2 prevalence in our cohort, and it's very similar to data from other studies. And so we see that HSV2 is incredibly common, more common in HIV-positive individuals versus negative, more common in women versus men. And these are similar trends across several studies in sub-Saharan Africa. And though HSV2 is very common, detectable genital ulcers are relatively more rare. So in a longitudinal sense, over the entire cohort, we see that 9% of study intervals for men were positive for detectable herpetic ulcer and 5% for women. And so this is basically, what I've shown you. We have a very high HSV2 prevalence, and then that's leading to a relatively, smaller proportion of people that are actually going on to develop these detectable herpetic ulcers, and that is actually what we see as the risk factor for HIV transmission in our cohort. So the objective of this study was to ask, well, what are these associated factors? We actually know a fair amount about what is associated with HSV2, but relatively little about what's associated with the development of these detectable herpetic ulcers. And of course, this limits prevention, early detection, early identification, and treatment. And so just to say the overall objective of this study and the final results slide that I'm about to present is asking the question, what are the associated factors for these recurrent detectable herpetic ulcers? And I don't have time to discuss all of the factors that come out of these multivariable models, but I just want to highlight a few that are bolded in these colors. So for men, detectable herpetic genital ulcer was associated with the man being HIV positive and having an increasing clinical stage of HIV in sort of this dose-response way. And was also associated with these more sort of inflammatory processes that I'm showing in blue, which including incident gonorrhea and chlamydia, and being uncircumcised with foreskin smegma. And then we see some relatively similar predictors in women. So again, we see that HIV positivity is associated with these incident herpetic genital ulcers, as well as this dose response for HIV stage versus being HIV negative. And then again in the blue, these what I'm kind of grouping together as potentially inflammatory processes, incident gonorrhea and chlamydia in women. We also saw non-STI genital inflammation was associated, and this is primarily discharge, BV, and Candida, and incident non-STI genital inflammation in the male partner. And so this is just sort of a recap of what I've shown you, the associated factors being HIV positivity and stage, and STI, non-STI inflammation, and circumcision and hygiene in men. And so just some brief implications. Of course, there are potentially many. Periodic screening for lesions in HIV discordant couples may improve lesion identification. Currently, the guidelines in Zambia are syndromic management of herpes and other STIs, but it is being discussed that perhaps we need to be recommending suppressive therapy for HIV positive people and potentially for positive people with a higher clinical stage. And screening and treating for causes of genital inflammation. And I think it's important to also really note and include the non-STI causes of genital inflammation in women, like BV and Candida, which we sometimes overlook, may be important to decrease lesion recurrence, as well as encouraging male circumcision and hygiene. And I just want to thank all of the collaborators and co-authors on this study, and of course the many funders that it took to run an 18-year longitudinal cohort study. Thank you.
Thanks, Kristen. So again, we'll open up the floor for questions. Maybe I can start with a question. So can you just clarify your definition of a herpetic ulcer episode? Because you didn't say that you did laboratory testing.
Right,
for-
so we don't have the PCR testing. What we're defining as an incident hepatic ulcer is an RPR negative ulcer. So we do have time-varying RPR measures. And so we are currently undertaking some sensitivity analysis around this, because I think it is, one of the probably potentially largest sources of bias. But considering that the majority of active ulcers are HSV2 related, we're comfortable that the majority of these are in fact due to HSV2.
Are there other questions, Sheena?
I think I'm slightly puzzling through my question as well, but one thing was I wondered what your hypothesis was for the factors in the male partner impacting on recurrent ulcers in the women. That was one question. And then the other thing is it's a staggeringly high prevalence of HSV2.
Yes.
So there must be a lot of concordant couples for HSV2. And then I'm just trying to think, how much does it matter?
So I think, for the concordance question, absolutely. About 60% of these couples were both concordant positive for HSV2, and about 30% were discordant. And then your previous question around the male partners' characteristics.
Yeah, what were you thinking?
So it's what the detail I'm not able to go into here, and some more of it is in the poster, that not everyone is HSV2 positive at baseline. So there's a lot of incidence that's occurring. And for those male partner characteristics, we're thinking that they are actually having a herpetic outbreak, and that's leading to incidence in women, and then that is a primary infection. So we can't tease apart primary versus recurrent, so it becomes pretty tricky.
The primary is key in
Absolutely.
populations that might have pregnancy.
Absolutely.
Thanks. I mean, Sheena mentioned the high prevalence. These figures are very typical,
They're
actually,
very similar.
of other populations in Eastern and Southern Africa, and it really raises important issues about how much HIV transmission is actually related to herpes simplex virus type 2. Are there any other questions?
Just maybe one quick question. Do you have any sense of what the prevalence of chancroid is in your cohorts?
Very low, less than 2-3%.
Good, thank you. I think we need to move on, so
Thank
thanks
you.
very much. So the author of the last presentation is Caravans Presentation. And are you Carrie?
Yeah.
Okay, because the computer told me someone else was presenting for you, but that's not true.
No, it's
Welcome.
me.
And you are a
Thank you.
PhD student
Yes.
based at...
Okay, can I introduce myself?
Please, because my paper doesn't tell me.
Yes, I'm a PhD student at the University of Cape Town, and I'm also a research staff at SESIMA at the University of Stellenbosch. So I will be presenting the first results of my PhD work, which has the ultimate goal of estimating the impact of different prevention strategies on cervical cancer in South Africa. But of course, as a first step in this very high HIV prevalence setting, we need to investigate whether, I also have to open my presentation. Yeah. We need to investigate whether the associations between HIV and HPV transmission is due to behavioral confounding factors, or are there really biological effects? And I have no conflicts of interest. So epidemiological studies suggest a 2 to 5-fold unadjusted increased risk of newly detecting HPV infection in HIV-positive individuals, and meta-analyses that adjust for behavioral risk estimate a 2-fold increased risk of HIV acquisition following HPV detection. So we simulated epidemics of HIV and 13 oncogenic HPV types using an individual-based model that includes distinct relationship types and allow for individual-level variation in rates of partner acquisition and propensity for concurrent partnerships. So the figure here at the top represents the natural history of HPV that we assumed in this model. So acquired immunity and viral latency is not well known for HPV, and I'm still investigating different model structures. And then for HIV, this is the model structure we use for this analysis. I'll present results on the pre-ART era in South Africa, so that's why there's no ART box. And importantly, in this modeling work, we used no biological effects to modify transmission parameters of HIV in the presence of HPV and the other way around. So a likelihood-based approach was used to calibrate the model to South African HIV and HPV-specific, type-specific prevalence data. I only present the model fit of the HPV data here, so the details on the HIV and the sexual behavior aspects can be found in this paper that I linked here. The figure on the left illustrates model fits to the 5 most prevalent oncogenic HPV types among young women aged 15 to 24-year-olds, HIV-negative girls, since they are the group at high risk of HIV acquisition. And the figure on the right shows a model validation. The model predicted overall HPV prevalence, so putting together all 13 types, compared to just one study in Cape Town. The 100 best fitting parameter combinations were used to simulate 100 cohorts with quarterly HIV and HPV testing between 2000 and 2002. So this figure shows model estimates of unadjusted hazard ratios, odds ratios, and incidence ratios calculated using the same methods as the studies shown here, and compared to the studies, compared to the estimates calculated in these observational studies. I compare the unadjusted estimates because these studies controlled for different sexual behavior and other factors, and I want the results to be comparable. So the simulated mean unadjusted hazard ratio for the effect of HIV on newly detected HPV is 2.1, with a confidence interval of 1.9 to 2.4. And so the simulated estimates are in line with studies that measured the effect of HIV status at baseline and with studies that estimated the effect of new HIV acquisition on HPV detection. The simulated estimates of the unadjusted effect of HPV status at study enrollment on HIV acquisition at some point during the study, and the unadjusted effects of the clearance of an HPV infection on HIV acquisition are in line with study estimates. And the one I think is most interesting, the modeled mean unadjusted hazard ratio of HIV acquisition at the visit following any detection of an oncogenic HPV type is 3.6 with a confidence interval of 2.7 to 4.5. Sensitivity analysis were performed as follows. We simulated 10 cohorts using the medians of all the parameters, and then we also increased or decreased the HIV and sexual behavior parameters by 50% or increased or decreased by 50%, and then we also increased or decreased the parameters for the HPV part, all 13 types simultaneously, and we can see here that by changing the HIV parameters, the hazard ratio differed between 2.9 and 3.8, and the sexual behavior parameters between 3.1 and 3.6, and then the HPV parameters between 3.2 and 4.6. So in conclusion, the model results are comparable to unadjusted results from observational studies, even when no biological effects were assumed in the model. So this suggests that observed associations between HPV and HIV transmission result from confounding by behavioral factors and network-level effects, implying that primary prevention of HPV by vaccination, for example, may not enhance HIV prevention.
Thank you very much, Carrie. So I'm sure there must be some questions on this interesting talk. Again, while people are coming to the microphone, maybe I could start. This will depend a lot on how you've modelled the transmission of these two infections, because the transmission dynamics, they're both sexually transmitted,
yes,
but the transmission dynamics of HPV and HIV will be very different. So there's probably not time to go into the details of how you've modelled the transmission, but can you briefly say how that is done and how they differ?
So in the background, the sexual behavior stuff is going on. So everybody can have at maximum 2 sexual partners, and they're in a high-risk group or a low-risk group. And then we model the 13 HPV types and HIV completely independently. So at each time point, so it's an individual-based model with weekly steps. At each time point, if somebody is at risk of HPV and has a positive partner, there's a probability of getting HPV, and the same with the other types.
Okay, and how does the transmission probability differ between the 2 infections?
Oh, a lot, of course.
A lot,
Yeah,
okay.
no, they have independent parameters, yeah.
Okay.
Yeah, yeah.
Are there other questions on this presentation?
Is there any cervical abnormality, cervical dysplasia?
No, not
put
yet.
Put into the model that might affect transmission risk?
Well, my clinical advisor said that there shouldn't be that much increased risk of HPV transmission in the presence of cervical lesions. So, there's no cervical disease stages here yet. I just lumped all HPV infections into one category for now.
Good, thank you.
Thank you.
So, Cara, I think we can let you sit down, and then we do have a few minutes left. We can probably take a few more questions on any of the presentations, if anyone would like to either make any comments or ask any further questions. If not, we will end early, but let's just... Yes, there's a question over there.
Thanks for an excellent presentation. I just, for the last presenter, Carrie, I think I just misunderstood your conclusion, and I'm trying to understand how treatment for HPV, given your findings, will not have any impact on HIV. Can you please elaborate a little bit more on that?
The observational studies that I showed there suggest that they controlled for sexual behavior factors and still found an increased risk of HIV acquisition if you have HPV. So what I'm trying to say is that I find that increased risk is there in the model, even without putting any biological effects into the model. So it has been suggested that HPV vaccination, if there is no HPV in the body, then it will reduce the risk of HIV acquisition. And I'm trying to say that I don't think that real risk is there.
So what, in terms of the public health and social impact, still what, for those who are trying to...
No. You should vaccinate for HPV. It will prevent you from getting cervical cancer. It will just not prevent you from getting HIV.
So it has to be said that there is some evidence, as Carrie was explaining, that HPV infection does enhance HIV transmission, but the evidence is not always consistent. It's not unequivocal. I have to say, I thought this was a really important area, that we then analysed our own data from Mwanza, and we were one of those studies, I think, that found no association, actually, between HPV infection and HIV. So the data do differ on this. I think we're unclear at the moment how strong, if any, this cofactor effect is. Obviously, if there is a significant cofactor effect, then HPV vaccination could potentially be a very useful intervention, not only against cervical cancer, but against HIV. But we don't know that. Are there any other... sorry,
I
Jeffrey.
guess just to comment on that, I guess the proof in the pudding would be a trial of HPV vaccination to see if it does reduce transmission, and whether you could do that ethically or not might be an issue. But
Yeah, we have a proposal for that. But if you know of any funders who would like to support that. Sheena, you have another question?
Well, it's yes, not specifically. I'm terribly sorry that I missed Florence's presentation, but I think I wanted to raise the question of hepatitis C. I wasn't sure if Florence might have mentioned that at all, but we've seen quite a lot of hepatitis C that's clearly sexually transmitted, and we've certainly been rethinking it. in the UK now that we're monitoring it more regularly. So I didn't know if this is something that you've picked up in the French data at all. But maybe you haven't looked for that, the co-infections.
We don't have the information in HIV surveillance or in... So we need specific studies on MSM to
look
to
at
have
that.
data.
Yeah.
Yes,
No, I think
about
I would
that.
really recommend people to think about that. I don't know, Jeffrey, have you done anything in the States on this at all? No. No, it really, but it seems very clear to us in a clinic where we're testing very regularly for hepatitis C that actually it's not just linked to injecting, and it's not just linked to HIV positive populations, which is what we previously thought. We're certainly seeing a lot of hep C, acute hep C in HIV negative gay men just from anal sex.
Another question on the right-hand
I was
side.
just going to make a comment on that, actually. Nick Medlin from Melbourne Sexual Health Centre. So we've got a poster upstairs looking at sexual transmission of hepatitis C in HIV-positive men who have sex with men. It's about acquisition about 1 case per 100 person years in our cohort. Anorectal chlamydia did not increase the risk. Syphilis increased the risk by about 5 times. So I think as we see an upswing of syphilis in this patient group, we may well see an increase in sexual transmission of hepatitis C.
Thank you. So if there are no more questions, Sheena, I think it was your idea to have this session.
Well, it's a collective idea.
Okay.
So, but I think I was to say that we really
Heard the plea for more on STIs for next year's conference, and it's great, as Richard says, to see the room full. I am a venereologist, so I'm absolutely thrilled.
So thanks to Sheena, and thank you to all the presenters and to you all for coming today. I hope you've enjoyed the session. Thank you.